Okay, regulation of osmolarity of the plasma, maintenance of electrolyte balance. Okay, for this function to remember or just to go through it, okay, we need to have the idea regarding isotonicity, hypertonicity and hypotonicity. Okay, last class we have done regarding the different functions performed by the different segments of the nephron. क्या हो गया? An important discussion? नहीं? Okay, in continuation with that, okay, two important functions which remain. One is the maintenance of plasma osmolarity and another is maintenance of electrolyte balance. Plus with this we will try to cover today counter current multiplier and exchanger system. So three objectives for today's class is plasma osmolarity, electrolyte balance and counter current mechanism. Okay. हिस्टोलॉजी की बंद कर दो ये, ठीक है ना? I have a better distant vision than near vision. Okay. Control of extracellular osmolarity. Okay, two important things which are required for this is ADH and thirst. Another name for ADH is vasopressin. Okay, thirst osmoreceptor system. To understand this thirst osmoreceptor system, in the next slide we will look forward how this mechanism works. Okay, and when it starts functioning, what are the stimulating factors? कहीं से भी whispering की आवाज आई ना, वो ही आके इस स्लाइड को समझाएगा. If you are not interested, don't enter, and if you have entered, you have entered by taking your own risk. So maintain silence. Increased extracellular osmolarity means increase in the concentration of sodium and chloride. Okay, that stimulates ADH release, which increases water reabsorption and stimulates thirst intake. Maximum urine concentration which can take place is 1200 to 1400 milliosmoles per liter. Please specify and see the specific gravity of the urine, which is in case of hyperosmolarity, it is 1.030. Minimal urine concentration can be 50 to 70 milliosmoles. Specific gravity changes to 1.003. Clear? So this change in the osmolarity, okay, the strength or the concentration of the solute depend on certain condition. If there is excess of water intake, or another condition can be one condition is excess of water intake, another just opposite condition can be dehydration, hypovolemia. Okay, one is the normal intake, another is the pathological condition. So pathological condition, one can be taking excess of water intake, another can be deprivation or dehydration. Okay, so two things which control or which regulate the osmolarity is, and the regulation can be, it must be that much severe that the osmolarity may reach to 1200 milliosmoles or minimum to 50 to 70 milliosmoles. In both the conditions, the specific gravity changes the urine. Okay, specific gravity of the urine changes. Water diuresis in human after ingestion of 1 liter or 2 liters. What will happen if excess of water is ingested? It will be excreted or removed from the body. It is simply intake of water. Okay, so if you remember, what do you mean by ORS? So it is not only the loss of water, it is the loss of electrolytes. So it is not only compensated by taking plain water, certain electrolytes has to be taken to maintain that balance, intake and output. Okay. Formation of diluted urine. What are the factors which will regulate or which will form the diluted urine or the concentrated urine? Previous lectures, we have seen the mechanism of urine formation in which 3 points are there: reabsorption, secretion and excretion. Once the urine has been formed, depending on the environmental condition and the dietary intake and the body requirement, the urine may be concentrated or may be diluted. So what are the factors which will make the urine diluted or which will make the urine concentrated? Okay, so continue electrolyte reabsorption. The first point is continuous electrolyte reabsorption, decreased water reabsorption. Okay, the first important point where the water reabsorption takes place is the PCT. The later is the collecting tubule under the influence of ADH. So if there is decrease in the water reabsorption, automatically the urine will be diluted. The filtrate is having more of the water content. Okay, the two important points where the water reabsorption takes place is PCT and collecting tubules. Okay, if there is decrease in the water reabsorption, automatically the filtrate or the urine formation will be of diluted nature. Clear? So the most important features which are responsible for diluted urine is continue electrolyte reabsorption. Whenever there will be the movement of electrolyte, automatically there will be simultaneously movement of water. Another is decreased water reabsorption. Okay, so this will result into diluted urine. That means the concentration or osmolarity will be 50 to 70 milliosmoles. Excess of water and less concentration of electrolytes. Sorry. Mechanism is decrease ADH release and reduce water permeability in distal and collecting tubules. Another feature is for concentrated urine. Okay, it is continuous electrolyte reabsorption and increased water reabsorption. Okay, increased ADH release, that will result into the increased water reabsorption, high osmolarity of renal medulla and counter current flow of tubular fluid. This will result into concentrated urine, that is the osmolarity is 1200 milliosmoles. Okay, the things which will be removed is urea, sodium chloride, water will be removed in excess. Okay, and so concentration will become 1200 milliosmoles. This is the obligatory minimum volume in which the urine will excrete the metabolic waste product. That is the obligatory urine volume. The minimum urine volume in which the excreted solute can be dissolved and excreted. This may change in certain renal pathological conditions. Okay, you might get questions like this to calculate it. Okay, for your exam purpose, you can go and do at least 2 numericals or example of this calculation. Okay, in problem based scenario, if you get in subjective paper or theory paper, you may be asked to calculate. Okay, so you need to remember certain formulas when we'll be dealing with the renal system. Okay, factors that now, okay, summary of tubular characteristics. These are the summaries you have to remember. Now the most important comes is the counter current multiplier system. First we'll talk of the multiplier system. If you remember, 3 things run simultaneously. That is the functions of the loop of Henle, counter current multiplier system and maintenance of medullary interstitium gradient. 3 things run parallel. Okay. For our knowledge point of view or understanding, we have divided into different segments or section. हर किताब में एक अलग-अलग फॉर्म में आपको दे रखा होगा. किसी ने एक साथ समझा रखा है, किसी ने इसको डिवाइड करके समझा रखा है, but they have explained it. Okay. So if the filtrate which is entering into the PCT is isotonic, तो first picture क्या clear हो रही है कि isotonic है, सब चीज isotonic होती हुई isotonic form में ये निकल रही है. 300 milliosmoles in the descending segment, 300 milliosmoles in the ascending segment. So the first picture says this is the case in the first scenario. What happens in the next is when 300 milliosmoles is coming, and as we know the ascending segment is highly permeable for the electrolytes or the different ions, sodium, potassium, chloride, calcium, magnesium. The thick segment is highly permeable for this. So when they are moving into the medullary interstitial spaces, they create a gradient, okay? So that gradient is of 200 milliosmoles. So if in ascending segment the concentration of the filtrate is 300, तो medullary interstitium की gradient कितनी होगी 500. Clear? So minimum it creates a gradient of 200 milliosmoles when the filtrate is moving in opposite direction. Counter current. Descending segment, the filtrate is coming in the downward direction. Ascending segment, the filtrate is going in the upward direction. So it is counter current flow. Okay. Multiplier, because it is increasing the osmolarity or the medullary concentration gradient. What factors are responsible for this increase is, first important factor is easy permeability of these ions in the thick ascending segment. Which are the channels which are responsible? कौन से चैनल रिस्पॉन्सिबल हैं जो कि मूवमेंट कराते हैं? लास्ट क्लास में देखा था अपन ने. 3 ions were moving in coordination. सोडियम to chloride and potassium. कैल्शियम और मैग्नीशियम किस मैकेनिज्म से ट्रांसपोर्ट हो रहे थे? Calcium, magnesium, paracellular. Why paracellular? Potassium was creating what? A wave of depolarization. That wave of depolarization resulted in the repulsive movement, and that repulsive movement was responsible for the movement of these ions through the paracellular pathway. Clear? So much of movement of these electrolytes, they are responsible for increasing the medullary interstitium osmolarity. So gradient created is 200 milliosmoles. Now the filtrate is coming continuously. ठीक है, ऐसा नहीं है कि एक पॉइंट पे GFR का filtration रुक गया. It is coming continuously. Okay, so once that filtrate has moved to the ascending segment, another filtrate will come. Okay, so it is a continuous process. So continuously increasing the 200 milliosmoles in such a manner that the medullary interstitium concentration gradient becomes 1200 milliosmoles, and when it is moving again towards the cortex, the concentration gradient becomes 100 milliosmoles. तो स्टोरी कहाँ से शुरू हुई थी? 300 से 1200, 1200 से 100, and then in the collecting duct again it will turn into 1200 milliosmoles. One of the important factor which is responsible for this medullary interstitium concentration gradient is urea. So collecting tubules जो होती है ना, collecting duct, उसके अंदर यूरिया ट्रांसपोर्टर करके कैरियर प्रोटीन्स होते हैं. ठीक है, ADH उनको इन्फ्लुएंस करेगा and they will be stimulated for release of urea. So urea is getting secreted at the terminal end, but it is getting secreted where? In the medullary interstitial spaces. So that is one of the important factors which is responsible for maintenance of medullary osmotic concentration of 1200 milliosmoles. ठीक है, तो ये इलेक्ट्रोलाइट जो निकले हैं ये मल्टीप्लाई करते रहेंगे. इधर से तो थिक असेंडिंग सेगमेंट से निकल रहे हैं और डिसेंडिंग सेगमेंट किसके लिए रिस्पॉन्सिबल है? वाटर रीएब्जॉर्प्शन के लिए. वाटर कहाँ होगा? लो सॉल्यूट से हाई सॉल्यूट की तरफ मूव करेगा. तो डेफिनेटली this movement will take place. Now this water and the electrolytes will be reabsorbed. So they have to get reabsorbed where? कहाँ होना चाहिए इनका reabsorption? मेड्यूलरी इंटरस्टिशियल स्पेस में तो रहेंगे नहीं इतनी देर, तो कहाँ रीएब्जॉर्ब होंगे? जीआईटी का क्या फोर्स था? ठीक है, च्यूइंग, मैस्टिकेशन, डाइजेशन, एब्जॉर्प्शन. एब्जॉर्प्शन कब माना जाता है? Until it enters into your, so they have to be reabsorbed. So where they will be reabsorbed? They will be reabsorbed in vasa recta. What are vasa recta? They are another set of capillaries which are present parallel to the loop of Henle, and they are responsible for reabsorption. How they work as reabsorptive? Because their flow is very sluggish. One of the important factor is the blood flow to the vasa recta is very sluggish, and they get 1 to 2% of the total renal blood flow. Okay, and the bulk flow and this pressure gradient and the osmotic pressure of the vasa recta capillaries, okay, hydrostatic pressure, all these factors, they create net effective filtration, reabsorption pressure, and the substances are getting reabsorbed into the vasa recta capillaries. Clear? But they are just the opposite picture. In loop of Henle, descending segment was responsible for reabsorption of water, just the opposite in case of vasa recta. Okay, but what vasa recta is doing is they are exchanging. So now the system becomes counter current multiplier exchanger system. तो अगर आपका क्वेश्चन आता है काउंटर करंट मल्टीप्लायर सिस्टम, वी आर टॉकिंग ओनली ऑफ लूप ऑफ हेनले. और अगर अपन बात करते हैं काउंटर करंट मल्टीप्लायर एक्सचेंजर सिस्टम, देन वी आर डीलिंग विद vasa recta. Medullary gradient, the difference between the filtrate and the medullary interstitium is of at same horizontal level, it is 200 milliosmoles, and that difference is created along with the ascending segment and the descending segment. But for us understanding purpose, first we'll go for the ascending segment, which is creating the interstitial pressure. क्या हुआ? एनाटॉमी खोली है, हिस्टोलॉजी खोली है, क्या खोला है एनाटॉमी का? कुछ नहीं खोला ना. So these are the scenarios. See, इधर 200 हो गया तो इधर 400 हो गया, ठीक है. फिर इधर 400 हो गया, धीरे धीरे आप डिसेंडिंग सेगमेंट में आ रहे हो, पानी यहाँ से रीएब्जॉर्ब होगा तो यहाँ की भी कंसंट्रेशन बढ़ेगी डिसेंडिंग सेगमेंट की, ठीक है. और यहाँ जाते जाते ये होगी, रिपीट स्टेप्स होती जाएंगे, एंड फाइनली दिस विल बी द सिनेरियो. Because continuous the filtrate is coming and continuous reabsorption and of water and electrolyte is taking place, and that is multiplying the effect. So it is counter current multiplier system. When we are dealing with the vasa recta, it becomes counter current multiplier exchanger system. Clear? So question अगर आपका आएगा केवल counter current multiplier, this is the thing which we have to write. If it has been asked counter current multiplier exchanger, then another picture will come. Net effect of counter current multiplier: more solute than water is added to the renal medulla, that is solutes are trapped in the renal medulla. Fluid in the ascending loop is diluted, so it is known as diluting segment. Okay. Most of the water reabsorption occurs in the cortex, that is in PCT, and the distal convoluted tubules. Horizontal gradient of solute concentration established by the active pumping of sodium chloride is multiplied by counter current flow of fluid. Okay. So whatever the things, recirculation of urea absorbed from the medullary collecting duct into the interstitial fluid, this is another important factor for maintenance of osmotic concentration. Okay, this is the amount which is getting filtered and enters. Okay, 50% is getting here, and then it is getting transported, and through urea transporter 1. Okay, these are the channels which are responsible, but they are influenced by ADH, and this is responsible for the movement of urea from the tubules into the medullary interstitial space. So very rarely the urea circulation or recirculation may be asked as a short loop exclusively. Very rarely, but it may be asked. Okay, it is passively reabsorbed in the PCT. Approximately 50% of the filtered load is reabsorbed. In the presence of ATH, what is it reabsorbed? Okay, and this is responsible for concentrating urea in these parts of the nephron. Inner medullary collecting tubule is highly permeable to urea, which diffuses into the medullary interstitium. ADH increases urea permeability of medullary collecting tubule by activating urea transporter 1. So whatever we have seen in the flow chart, that is written as subjective. So if you have ample of time, both the things should be present in your copy. But if your time management fails, at least you can give a flow chart for explanation purpose. Okay, this is the vasa recta preserve hyperosmolarity of the renal medulla. So how this picture takes place, and this is the story of vasa recta. So when vasa recta comes into picture, it becomes as counter current exchanger. Vasa recta blood flow is low, only 1 to 2% of the total renal blood flow, and the flow is very sluggish. So it has ample of time for exchange to take place. If the flow will be very high, then it will have less time for exchange. So for exchange to take place, the flow of vasa recta blood is very sluggish or slow. Okay. Changes in the osmolarity of the tubular fluid in what different segments? What is the osmolarity of the fluid? Okay. Summary of water reabsorption and osmolarity in different parts. Okay. This much I think you might be clear till now. Free water clearance. Okay. Disorders of urine concentrating ability. What will happen if ADH does not function properly? Okay, it is not secreted. Now just to understand, okay, what are the factors which will stimulate the release of ADH? कौन से ऐसे फैक्टर्स होंगे जो कि ADH के सिक्रीशन को इंक्रीज करेंगे? हाँ खड़े हो? ब्लड प्रेशर, ठीक है, ब्लड प्रेशर इंक्रीज और डिक्रीज ब्लड प्रेशर? Decrease. Good. Another factor which will be responsible for ADH secretion? Two important factors which are responsible for the secretion of ADH is blood pressure and increase in the sodium chloride concentration. Okay. So decrease in blood pressure, what are the conditions in which they kindly decrease in blood pressure? What are the conditions in which a person can have low blood pressure? लो ब्लड प्रेशर में टेकिकार्डिया होता है, टेकिकार्डिया के कारण ब्रेडिकार्डिया, ब्लड प्रेशर कौन कौन से फैक्टर्स के ऊपर डिपेंड करता है? What do you mean by cardiac output? It is amount of blood, है ना? Stroke volume के ऊपर डिपेंड करेगा. So if the person is having hemorrhage, trauma, dehydration, what will happen to the amount of blood present in the body? It will decrease, है ना? तो क्या होगा? Blood pressure will fall. Okay. So when there is condition of burns, hemorrhage, trauma, injuries, okay, first all the substances will be decreasing. All the substance means plasma and formed elements. So composition of blood has to be very much clear. कोई भी सेक्शन अपन फिजियोलॉजी का पढ़ते हैं तो उसके अंदर बेसिक चीजें पता होनी चाहिए, ब्लड, है ना? So whenever these type of conditions occur, first initially there will be decrease in plasma as well as in formed elements. When there is decrease, then definitely there will be decrease in the blood pressure. That has to be corrected. So body has that mechanism to correct it. So the first important thing which will come into action is secretion of ADH. Okay, so ADH, it is getting formed in hypothalamus. Okay, two important nucleus which are responsible for its formation. Okay, they will be forming ADH, that is vasopressin. Okay, now it will be formed in hypothalamus, stored in posterior pituitary, and it will be secreted. So there are osmoreceptors which are present on hypothalamus. So these osmo means they are sensitizing the osmolarity of the blood. So osmoreceptors which are present, they will sensitize the change in the concentration of sodium chloride. Definitely when there is decrease in the amount of blood, definitely there will be change in the concentration of sodium chloride. Okay, so these osmoreceptors, they will sensitize the change in the osmotic concentration or osmolarity of the blood. So you should be clear what is the osmolarity of the blood. So the range of osmolarity of blood is 280 to 295 milliosmoles per liter. Clear? Roughly we are saying 300 milliosmoles when we are talking of this particular scenario. But you need to remember the range of plasma osmolarity. Okay. Now these osmoreceptors, they get signal, they get stimulated. Okay. Now they will be asking the posterior pituitary to release ADH. Okay. Now this ADH when comes into the action, where the target cell is present for this ADH to take place, action, कौन से सेल होते हैं? लास्ट टाइम पढ़ाए थे 3 सेल्स. ADH क्या कर रही हो? ADH के लिए कौन सा सेल था? अपन ने 3 टाइप के सेल्स पर्टिकुलरली पिछली क्लास में पढ़े थे और मैंने बताए भी थे कि इजीली रिमेंबर करने के लिए A, B और प्रिंसिपल सेल. So ADH will come and affect the principal cell. Okay, and by which mechanism? By second messenger mechanism. When you will study endocrinology, okay, endocrine का जो topic आएगा तब आप पढ़ोगे तो उसके अंदर आएगा second messenger mechanism. So on the principal cells we have a particular type of receptor that is known as V2 receptor. V stands for vasopressin. Okay, vasopressin से आप क्या समझते हो? It is pressing the vessels. So one of the receptor which is responsible for the action of ADH is present on the principal cell, and where? On the basolateral surface of the principal cell this V2 receptor is present. अब अपन ने इसको V2 बोला तो V1 भी होगा कोई receptor. So this V1 receptor is present on the efferent arterioles. Okay, ADH कब स्टिमुलेट हो रहा है? जब ब्लड प्रेशर कम हो रहा है, उसको क्या करना है? ब्लड प्रेशर बढ़ाना है. ब्लड प्रेशर बढ़ाने के लिए उसको क्या करना पड़ेगा? वेसल्स को कंस्ट्रक्ट करना पड़ेगा. तो उसका V1 रिसेप्टर सारी वेसल्स पे एक्ट कर रहा है, पर स्पेशली efferent arteriole पे. So V1 receptor which is responsible or which is giving the name vasopressin to ADH because it is responsible for pressing the vessels. So this V1 receptor present in the efferent arteriole, V2 receptor present on the basolateral surface of the principal cell. Here, so when this ADH comes, it joins with the V2 receptor inside the cell. Okay, the mechanism takes place, and this mechanism is known as by second messenger mechanism. ये आप एंडोक्राइन में पढ़ेंगे, फिर भी मैं बता देती हूँ. When it gets attached, stimulated G protein, okay, there is presence of GS protein which will be asking adenyl cyclase. Okay, adenyl cyclase change करेगा and there will be formation or presence excitation of pKa protein kinase. Okay, and that will be resulting into the formation of channels. Okay, with cycles बनाएंगे, channels बनाएंगे, और channels कौन से बनाएंगे? Aquaporin 2. और क्या करेंगे? इसका चेंज कर देंगे. Initially they are present in the cell, but due to the presence of this second messenger mechanism of ADH, through which receptor? V2 receptor. So what it will do? It will align the aquaporin 2 channels on the apical surface. Okay? क्या कर देंगे? अलाइन कर देंगे एक्वापोरिन चैनल्स को, और स्पेशली कौन से चैनल्स को? एक्वापोरिन 2 को. और कहाँ पे? ल्यूमिनल साइट. तो क्या कर दिया? अलाइनमेंट कर दिया एक्वापोरिन 2 का, तो ज्यादा से ज्यादा रीएब्जॉर्प्शन होगा. बट सेल कैन नॉट अकोमोडेट एक्सेस ऑफ वाटर. इट हैज टू बी मूव फ्रॉम द सेल इनटू द medullary spaces and from medullary through into the blood. Okay, so what will happen? The aquaporins 2 is present on the apical surface. 3 and 4 they are present on the lateral and basolateral surface. तो एक्वापोरिन के 3 चैनल्स हो गए, 2, 3, 4. पर एपिकल सरफेस किसके लिए रिस्पॉन्सिबल है? ल्यूमिनल सरफेस से वाटर रीअब्जॉर्प्शन. और वो किसकी इन्फ्लुएंस में कर रहा है? एडीएच की. कौन से रिसेप्टर के हेल्प से कर रहा है? V2 रिसेप्टर. मैकेनिज्म क्या है? सेकेंड मैसेंजर मैकेनिज्म है. क्या कर रहा है? अलाइनमेंट ऑफ द वाटर चैनल. बाकी 2 चैनल्स जो प्रेजेंट है वो कहाँ पे हैं? लेटरल सरफेस पे और बेसोलेटरल सरफेस पे. वो ऑलरेडी एग्जिस्ट कर रहे हैं, प्रेजेंट है. उनका कोई अलाइनमेंट ऐसे चेंज नहीं हो रहा, बट दे आर रिस्पॉन्सिबल ऑफ वाटर मूवमेंट फ्रॉम द सेल इनटू द इंटरस्टिशियम एंड देन इनटू द ब्लड. क्लियर? सो इफ देयर इज प्रॉब्लम इन द central nervous system, that is hypothalamus or posterior pituitary, okay, there may be trauma, injury, any kind of problem resulting into the hyposecretion of ADH. क्या कंडीशन हो सकती है? कि ADH हाइपोथैलेमस और पोस्टीरियर पिट्यूटरी एक्सिस से आ ही नहीं रहा है या कम सिक्रीशन हो रहा है. ठीक है, तो क्या होगा? इट विल बी रिजल्टिंग इनटू द कंडीशन दैट इज नोन एज सेंट्रल diabetes insipidus. So diabetes insipidus 2 types. ठीक है, central, why we are calling it as central diabetes insipidus? It is involving central nervous system. Clear? So there will be hyposecretion of ADH. Another scenario may be there is proper secretion of ADH, but that is not acting properly. So acting के लिए इसको क्या सबसे important है? Receptor. Okay, so there may be hypofunctioning of the receptor, there may be absence of receptor. Okay, so if this condition takes place and due to this condition the diabetes insipidus is taking place, it becomes nephrogenic diabetes insipidus. Clear? Diabetes insipidus, central and nephrogenic. So for understanding of this ADH, so when there will be excess of water reabsorption, okay, है ना, तो वाटर का एब्जॉर्प्शन होगा, तो ब्लड की जो हाइपर ऑस्मोलरिटी मीन्स इंक्रीज इन द कंसंट्रेशन ऑफ सॉल्यूट. ओके, so hyperosmolarity has to be corrected. So what is the mechanism? You have to reabsorb water. Once the water enters into the blood, the osmolarity will be maintained or corrected. Another factor क्या था इसका responsible? Decrease in the blood pressure. Okay, so decrease in blood pressure is controlled by reabsorption of water, increasing the blood volume, and second receptor was acting at the afferent arteriole. So there will be vasoconstriction that will increase blood pressure. Okay, so these 2 mechanisms will control the 2 stimulating factors. This is the story of ADH, and with the help of ADH, the plasma osmolarity and the regulation of electrolytes both are done simultaneously. And if this condition fails, this is the condition. ये तो क्या कहानी हो गई अपनी? When ADH is low, what happens when ADH secretion is more? Can you see the topic? Total renal excretion and excretion per nephron in renal failure. Okay, this is the story of normal, and this is when the 75% of the nephrons are lost. Okay, so this will be the change in scenario. Number of nephrons, you can see change. Total GFR 125 to 40. GFR per nephron, it is nano. Okay, so it becomes 80. Total urine flow rate 1.5, 1.5. Volume excreted 0.75, and it is 3. Okay. So this is the mechanism. Osmoreceptors, antidiuretic feedback mechanism for regulating extracellular fluid osmolarity. So what we have talked is this. Okay. Water deficient. What are the conditions in which dehydration? Okay. Water dehydration. What will happen? Extracellular osmolarity will definitely increase. Okay. Who will sensitize it? The osmoreceptors present at the hypothalamus end. Okay. What it will do? It will ask the posterior pituitary to secrete more of the ADH. Okay. Then what will happen? There will be increase in the ADH. Okay. What it will do? It will increase the permeability, okay, of the collecting tubules. So mechanism for that is by V2 receptor, second messenger mechanism, okay, and opening of aquaporin 2 channel. Okay, increase in water reabsorption, okay, and more of the water excreted, and this is corrected. Okay. ADH synthesis in the magnocellular neurons of hypothalamus, released by posterior pituitary and action on kidney. Okay, this is the axis. Okay, and it is coming and it is affecting which part of the nephron. Clear? 30% of the students, I think they are listening. Rest are just physically present, not mentally present. Okay. Increased osmolarity, decreased blood volume, decreased blood pressure, and other stimuli are input from the cerebral cortex. Angiotensin 2, nausea, nicotine, morphine. These are the drugs and the effects which are responsible for the, okay. Stimuli for thirst is increase in the osmolarity, decreased blood volume, okay, decreased blood pressure, increased angiotensin 2, and other stimuli is dryness of mouth. Factors which decreases thirst is just the reverse, okay. These are the factors which will be responsible for decrease in the thirst. Okay. Sufficient for today? कितना टाइम हो गया?